Okay, let me spotlight.
So we have to click on the got it.
Mhm.
Okay, I see.
Okay, thanks everyone for joining us again after a little bit of a break over the summer. We've taken it easy. It's my pleasure to welcome Dr. Bill Salt to our discussion in diagnosis this morning. Dr. Salt is an integrative gastroenterologist based in Columbus, Ohio, not too far from here, obviously. And he is going to talk to us a little bit about a really vexing problem in primary care, and that's the diagnosis of IBS. And I just visited his website a couple times, and I do exactly what a lot of primary care physicians do, is if they've got a little bloating and abdominal pain, and it's going on for a reasonable length of time, I kind of declare that you don't have anything too serious going on. You've got IBS, and let's start to treat it. So welcome, Bill. And Bill has another guest with us this morning, Mr. Raf Megar, who is a colleague of Bill's as well. And I'll allow you both to introduce yourself. Bill, would you like to start?
Sure. So I practiced conventional mainline gastroenterology in Columbus, Ohio for some 35 years. Was one of the founders of the Ohio Gastroenterology Group. We were the very first mega group to form in the country, from which there was much replication. And then I burned out. And in 2009, I tried to retire to Florida with my wife and failed the course, and then met the definition of insanity and returned and rejoined them for a short period of time. Didn't go well, because my interest has always been in patients who are otherwise recognized as having irritable bowel syndrome. That's not an interest of gastroenterologists. These patients are therefore stuck in the middle. And I have my own practice, and I met Raf through research with Mark Pimentel in California, and we think we've got a better way of doing things.
Terrific. Raf, would you like to introduce yourself briefly?
Sure, very briefly. Good morning, everyone. My name is Raf Megar. I run a research and consulting firm focused primarily on health economics and outcomes research for the past about 26 years. How I got connected with Dr. Salt, as he indicated, through a research project, is about maybe 2.5, 3 years ago, when we were discussing a project with Dr. Salt and looking to board his practice into the study. I learned through conversation with him that he was getting much better outcomes as related to managing these IBS patients in terms of efficacy, with, for example, a treatment like Xifaxan from about the 41, 42% to as high as maybe 60%. And I found that intriguing. And over time, what I learned from Dr. Salt is that it came down to the accuracy of the diagnosis. And once you had an accurate diagnosis, then you could treat, much more effectively. So that started the process of our collaboration in developing a program that looks at the accurate diagnosis and the more the effective diagnosis of IBS over time. And we're in the process of actually collecting data to demonstrate, essentially establish best practices.
Thank you, Raf. So, Bill, I'd like to start with the common scenario that we often face. And for those of us who are on the discussion this morning and come from the world of primary care, or perhaps even specialty care, will be very familiar with it. So I'm seeing a 65-year-old woman who's generally healthy. She has obesity, she has hypertension, but nothing else really. She is reporting abdominal pain over the past 3 months, described as crampy and diffuse. She doesn't have any prior episodes. She's got no nausea, vomiting, stool changes, weight loss, change in appetite, fever. She's generally well besides the pain. She doesn't have much of a past history. She had a hysterectomy in 2011. Denies depression, anxiety-related condition, and I know absolutely nothing on the physical exam. And there's many different directions I can go. Given her age, you might wonder if there's some sort of underlying malignancy, although unlikely. She's had a hysterectomy or oophorectomy, so a reproductive tract malignancy is unlikely. So I'm thinking IBS, but I know that this is your sweet spot, and a lot of primary care physicians would probably go that route, treat her empirically, see how she responds, And if not, refer her to gastroenterology. And as you mentioned quite accurately, they are not especially interested in IBS, so they would probably do an endoscopy, upper and lower, and then send her back to me. So what would be your approach to this patient?
Yeah, you said so many important things there, so many important observations. So the first key point here is that she cannot have IBS. And there are two reasons for this. She has not had the symptom, if she's accurately describing her history, she has not had the symptoms for at least 3 months, having symptoms pretty much, well, 1 or 2 times a week. And most importantly, she does not describe any association of the pain with bowel function. Mm-hmm. So we could launch into a discussion of what might be wrong with her, but I think the key point here is that this is such a common issue for patients who are presenting with belly pain, younger patients particularly, where we make a gestalt diagnosis. They don't have any red flag alarm features. They don't have blood in the stool. They're not losing weight. They don't have a scary family history, and they get diagnosed with IBS. That is a big problem, as Raf and I see it, because IBS is technically what we are now calling a disorder of gut-brain interaction, a DGBI. And you're probably somewhat familiar with that term, but we used to call this functional gastrointestinal. Sure. The terminology has been changed. That word doesn't really help patients understand. So there's a disturbance of brain-gut communication. Everybody knows there's a little brain in the gut, and they're not talking correctly. And so we get spasm and we get secretory abnormalities, etc. But in reality, these patients present with a symptom complex. It's a triad of symptoms, and I think that's a key point I want to leave you with. What do they have? They have abdominal pain, and they may not call it pain. They may call it discomfort, which, by the way, has been removed from the technical definition of IBS, which makes no sense to me whatsoever. They have bowel dysfunction, diarrhea, constipation, or both. There's usually a linkage. And very importantly, they're all bloated. And they often use the term bloating, but they really mean distension. So you want to clarify that with them. And the point we want to stress here is that that's a symptom complex. There's an ICD-10 code for this. It's K63.9. One cause of that is IBS, the DGBI. Mm-hmm. But Raf and I would propose there are 6 other classes of disorders and diseases that need to be considered before that diagnosis is rendered, and they can have IBS plus 1 or 2 of these. An example, we now realize the vast majority of patients who have IBS have gut microbiome dysbiosis, small intestinal bacterial overgrowth. And then if you find that calls into question, what is the underlying reason that they have this? What is the small bowel problem? And a search is necessary. For example, Mark Pimentel in California, working on patients with these patients for 20-some years, has now developed 2 key tests, one of which is the Trio Smart breath test, state-of-the-art breath testing, and the other a blood test, the IBS Smart blood test, which, when positive, indicates that patient has had a prior bacterial gastroenteritis and now has an autoimmune ongoing problem impairing their migrating motor complex, so their small intestine doesn't cleanse itself out in the fasting state. This then allows SIBO to occur. We like to call these 6, just to make it easy, the pick 6, to use a football analogy, because quite frankly, Raf and I are proposing a paradigm shift. We do not think that changes are going to occur with my colleagues. They really do not want to see these patients. Let's just be honest here. And we believe and we hypothesize that this can be done by primary care specialists.
Okay, that's interesting. So you're advocating a whole new approach to diagnosis. So you and I have had a couple of email conversations about the Rome 4 criteria which, even in supervising residents and medical students, I often mention, why don't you go look those up and see how you make a diagnosis of IBS? How do you feel about the application of those criteria?
Well, when I would look in the records of my colleagues in the group,
Mm-hmm.
I could actually find almost never would I find any reference to those criteria. So the reality is they are not practically applied. They are largely research tools, and they just aren't practical. And I think it would be very unusual to find it in the primary care specialist records. So we just don't think it works. And that's one of the big problems. I think it's been complexified unnecessarily.
Mm-hmm.
We think we have a way to unwind this so that a primary care specialist could recognize, quite frankly, you recognize that symptom complex, that triad of
Mm-hmm.
symptoms, that collection, and then you just make a major decision. What is the primary and predominant bowel dysfunction? Is this patient purely constipated? That's one pathway. Or do they have diarrhea? And they can have some constipation with that. If it's pure diarrhea, that's the so-called IBS-D pattern.
Mm-hmm.
If they've got some constipation in there and they've got some alternating function, that's really an IBS mixed, but we combine D and mixed, and so we call it D/M, because that differential diagnostic pathway is different from a purely constipated patient.
So let's get back to the scenario then. So this lady does not meet the criteria for IBS. Her symptoms are not of adequate duration. It's not related. It's very diffuse, perhaps not related to any bowel movements, nothing of the sort. And she may even be frustrated because she's seen somebody else who's kind of dismissed her symptoms or not taken them seriously and says, no, you're doing very well. What would be your approach to that at that point?
Yeah. Well, I had responded to you on that one because most importantly, she doesn't have IBS. She is of an age group, obviously over 50, that we need to understand. We need to render a diagnosis here. Mm-hmm. She may have had these symptoms for longer than we think. I'd like to try to understand from a primary care perspective what is going on in her life. Any new medicines, is there stress, dietary changes? Frankly, what does she think is causing it? There's so many times if we give that patient the opportunity to tell us what's going on, they're going to go ahead and reveal it. Is it colicky? We're trying to decide whether it's a constant, steady kind of pain. That's mm-hmm. a solid organ type origin, mm-hmm. or is it cramping and colicky? That's a hollow viscous problem. Mm-hmm. So she sounded to me by the case like this was a small intestinal or colonic problem. Could she have a partial small bowel obstruction? Adhesions can manifest with obstruction, as we know, decades later. Could she be taking NSAIDs and aspirin and ulcerated or small intestine? Is she hypertensive? Well, she is hypertensive. She is hypertensive. ACE inhibitor or ARB inhibitor? I'm impressed how often angioedema, I think it's under-recognized, associated with these drugs, which can, well, they usually occur within the introduction of the drug, but this can evolve months to years later. So I would be concerned too, if she's really accurately reflecting her story, what is going on in her colon? Colon cancer can present with pain. They don't necessarily have to have bowel dysfunction. They may not tell us that they have bleeding. So we need to know if she's had a colonoscopy anytime recently in the last 2 to 3 years. I'd be concerned. She's of the age group that's in our differential diagnosis. So we don't know what she has, and we know it's not IBS, but she does require a diagnosis. So I probably would offer imaging to her.
Okay. That's some great points that you just made. So this is a woman who is seeking help for this condition, who's generally been healthy. So it's obviously serious enough that it's affecting her life in some way. And you mentioned a fairly broad differential. So what sort of imaging would you get at this point?
Well, either a CAT scan or an MRI. Mm-hmm. And she's older. I don't like to use CAT scans in young people. I think a CT would be reasonable. I think it's important when you think that the hollow viscous is involved, small intestine, colon, to ask for an enterography technique imaging study. And this then involves including both oral and intravenous contrast, because if you don't do that, you can easily miss problems, significant problems in the hollow viscus.
Okay. So I think that your concern is that there is an underlying serious condition which we're missing, obviously. I think that a lot of people in primary care and perhaps in gastroenterology as well would not be as thorough, and they would consider empiric treatment for IBS. I mean, obviously, a lot of medications are being promoted now. There's ads on TV, that sort of thing. What do you think the role of those medications is in terms of helping us make a diagnosis?
Yeah, in this case.
Yeah, in this case.
Okay, well, I don't think drugs like Xifaxan apply because all of the IBS drugs are directed to bowel dysfunction and the pain, of course. But we don't have a case of IBS here. So there is no applicability as I see this case.
Okay. Well, I think that the big thing we'd like to speak to you about, given your work and Raf's work in this area, is how do you see the future of diagnosis of IBS and related conditions moving in the next few years?
Yeah, well, that is exactly what floats our boat.
Yeah.
We don't see it changing in the hands of gastroenterologists. The average time that it takes to diagnose an IBS patient by research is 6.5 years. We think this needs to be done. These patients are going to continue to flounder unless this can be done by primary care specialists. 1 out of every 10 patients seen by a primary care specialist technically has IBS. And we think, though, that the successful treatment can be done non-invasively in the large majority, that is with blood testing, breath testing, stool testing, arriving at a diagnosis. 3 different categories. They have a pure disorder of gut-brain interaction. In my opinion, that means they don't have any of the PIC6, then that's unusual. And it's primarily unusual because the vast majority of them have gut microbiome dysbiosis. And that then means they don't just have pure IBS. So you can have a patient with DGBI IBS. You could have 1 or more of the PIC6. Let's say they've got gut microbiome dysbiosis. Most of them have more than 1. What else? Sucrose intolerance. We now realize the inability to break down sugar is extremely common in bloating and distended patients. And that's totally treatable. If they've got diarrhea, 1/3 of patients with the diarrhea IBS symptom complex have bile acid malabsorption. You can completely relieve them of those symptoms by giving them a bile acid sequestrant. So that gives us 3 different categories. Pure IBS, we don't see it very often. Could it be 1, 2, or 3 of the disorders or the PIC6? All of them are treated. All of them are specific therapeutic targets. Or could it be what Raf and I call IBS plus? That's IBS. They've got features of IBS as we all know it, and they've got 1 or more of the PIC6. So this means that the successful treatment of the IBS patient is wholly dependent upon an accurate initial diagnosis.
Okay. So the picture is emerging. So this lady comes in, or someone similar to her, and I don't make a diagnosis of IBS, but I am concerned about some serious underlying conditions, such as you mentioned, a partial small bowel obstruction, and I may obtain imaging under those circumstances. Then I'm looking at some of these other conditions as well, gut microbiome dysbiosis, and what's the most efficient route to diagnosis of those conditions? Let's say there's nothing on imaging. I found nothing that I'm terribly concerned about in the acute period.
Okay. Now, we're talking about a patient that has an IBS profile rather than this case. Yeah.
Yes.
Yeah. Okay. So I'm going to conduct both of those tests that I was describing. That are the company. It's Gemelli, Gemelli. That's Gemelli Biotech. That's Mark Pimentel's company with Cedar Sinai. I'm going to conduct a breath test, the Trio Smart breath test. If they have a diarrhea dimension to the problem, I'm going to conduct the IBS Smart blood test.
Okay.
There's a carbon-13 sucrose breath test that's very accurate that can be conducted at home, just like, by the way, the IBS or the Trio Smart breath test can be conducted at home. I'm going to do that too. I'm going to send off a Mayo Clinic 7AC4 bile acid synthesis serology, which is usually elevated if they have bile acid malabsorption. If they have a pure constipation disorder, I'm going to use a simplified colonic transit test called SITZMARKS, SITZMARKS, which this can be done by primary care specialists to try to identify what's going on in terms of really you want to look for those pick six. That's what's so treatable about these patients that's simply not being done.
Okay, well, thanks very much. So I think we've just got a couple of minutes left, Bill. So I'm going to throw it open and see if we've got any questions. And I had a question as well, but I'm going to ask others to go first. Let me just scroll through here. Any questions for Dr. Salt?
Hi, yes. My name is Sarah Koopman Gonzalez, and I had a question just regarding the research that you are doing right now to demonstrate the efficacy of this. Could you talk a little bit more about that and when you anticipate having those results?
Yes. I have a book that explains all this that I've had available to my patients for 5 years now, and I've just put a new version of it up there. It's entitled You're on Fire. The electronic version of that is available in the online bookstores. The print version will be available in about a month. Raf and I want to conduct and are getting ready to conduct a pilot trial with a small group of family practice specialists, 2 physicians, 3 advanced practice providers, to work the kinks out of what I've been doing myself for 10 years and to essentially prove the hypothesis just in a small group, a small practice. And then we want to take that into a larger group with a number of specialists who are interested in this that we would train. We would train not only the physician and the advanced practice providers, but their support personnel, because we want to make this very, very, very easy for the primary care specialist. I capture my history with a designed form. So I know what's going on with my patient most of the time before I even work with them. And I think that's very important. You have very limited time. And again, we're going to focus on recognizing that triad and what is the predominant bowel dysfunction. That's the key that you need to do. You have to make sure they don't seem to have any of the red flag features, bleeding. They would need a colonoscopy for that. Obviously, you're concerned if they're losing weight. Although I have to say, I'm interested with your project, Ralph, because you and I both know that most of the time a person is losing weight, and unless something is pretty evident on standard evaluation, you can't find the reason. So it's along that line. So we are very excited. Then with Raf's help, we want to conduct the research, the kind of thing that you're doing with your Center of Excellence. We want to prove 2 things. That's a happier patient. That's a satisfied patient. That's an outcome that we're not getting now, the way these are approached. And then we want to show that they don't have to get to a gastroenterologist, get unnecessary testing, get an unnecessary set of scopes, and not get any help. So as Raf would say, if you can prove both of those things in the world of healthcare economics and outcomes research, that's what's called dominance. And so we have a very ambitious view of this and a very ambitious vision, but we are totally convinced it has to happen with primary care specialty.
Terrific, Bill. And just one last question. I know we've only got a minute left, but you mentioned a series of tests from the biotech company that's based out of Cedars-Sinai. Are those widely available, or how would we order those if we wanted to?
Yes, they are widely available. And if I can actually put you in touch, Goutham, with, for example, the CEO of the company, who would help you deploy them. And you can learn how to use them with my information, with my materials. But that's exactly what we are hoping to inspire, that this can be done by primary care people and that they don't get to gastroenterologists where they don't get this help.
Okay. Well, thank you so much, Bill. Thank you, Raf, for joining us this morning. It was a fascinating discussion. And I'm sure we'll hear much more about this. We'll probably get lots of messages. So this will be posted on YouTube as well. So you may get some additional inquiries too. So thanks, everyone. Have a wonderful day, and we'll talk to you soon. Bye-bye.
Bye. Thanks for having me.